Can I continue?
Yes, yeah, sure.
Okay. 2. Which of the following is correct about the descending colon? Intraperitoneal, primarily retroperitoneal, secondarily retroperitoneal, supplied by superior mesenteric artery, none of the above. Descending colon. Okay. Supply inferior mesenteric artery is not intraperitoneal. It's the retroperitoneal organ.
Yeah, it is retroperitoneal. Descending colon is retroperitoneal.
Mm-hmm.
What is the meaning of like primary versus secondary retroperitoneal? What does that mean? Primarily retroperitoneal versus secondarily retroperitoneal means that during development, embryonic development, right? It was intraperitoneal, but then it came to a retroperitoneal location. That's called secondarily retroperitoneal. But if it's from the get-go, like it originates in retroperitoneal location, it stays there, that's called primarily retroperitoneal, like kidney, like suprarenal gland, like ureter. Those are primarily retroperitoneal. They've developed there and stayed there. But if an organ developed inside of the abdominal peritoneal cavity, but then later moves to a retroperitoneal location, that's called secondarily retroperitoneal. That's like ascending colon, like descending colon, right? Like pancreas. Those are all organs which used to be intraperitoneal. Okay? So for that question, it's option C, right? Answer is option C. Okay, let's see the next one. Yes. Yes, doctor, can you hear me?
Yep. A patient presents with suspected septic arthritis. Which of the following is not typical found? White blood cell count over the 16. Fever is higher than 38 centigrade degree. Unable to bear weight. CRP elevated and platelet count elevated. It's I think E, platelet count elevated.
Yeah, yes, right. So that's not typical. It is not in the criteria for the diagnosis. You know, criteria, the Kocher criteria for the diagnosis of septic arthritis, they call it WIFE, right? Mnemonic WIFE, white cell count high, inability to bear weight, fever, elevated ESR, right? It's not it's not a typical finding. Of course, there may be reactive thrombocytosis and inflammation that can happen generally, but that's not typical of septic arthritis. Is that right? So it is, by the way, anyone can like give us an insight about if you have a case of septic arthritis, how are you going to deal with that? What's the treatment of choice? What's the first thing that you do if you have a confirmative diagnosis of septic arthritis? Anyone? Yes, Fabia, very nice. So it means that you need to decompress the joint. You need to decompress the joint. Like arthroscopic decompression of the joint. Why you have to do, why that's urgent? Why can't you just like give antibiotic and wait and see what's gonna happen? Maybe give some fluids, analgesic, those stuff. Why are you gonna have to move in and decompress the joint quickly? Well, no, not for pain relief. It's not the primary objective. It's because if there's rapid destruction of the cartilage, right? If in septic arthritis, destruction of the articular cartilage is very, very quick. So it means you have to decompress quickly. Otherwise, there is irreversible damage to the cartilage. Now I have a question, and if someone answers it, I'll be very, very impressed. Although I said it's in the lectures, but I'll be very, very impressed. That is, why is it so that in infants, if they have osteomyelitis, why is it so that in infants, extension to the articular surface is more common? That is, if they have osteomyelitis nearby a joint, septic arthritis develop more likely in the infant as compared to children and adults. That was a question in the past. Anyone knows the answer to that? Yes? No answer? Okay, maybe we will leave it to that. Muhammad said, can you like elaborate? I didn't understand. Okay, we'll leave it to the end, but you have to remind me, okay? I'm going to talk about it in the end, but you remind me. Okay, let's see the next question. Yes, doctor? Yeah, doctor, are you with me?
Okay.
Yeah.
A 60-year-old man with end-stage cancer is on multiple drugs and he develops peripheral neuropathy. Which of the following drug is the most likely underlying cause? Septicumab, oxazimab, 5-fluorouracil, methotrexate, and doxorubicin.
Yeah, so what do you think?
Oxaliplatin.
Yeah, very excellent. Oxaliplatin, that is associated with peripheral neuropathy very well, right? Especially when there's exposure to cold environment, it's more likely to cause neuropathy then. Okay, let's see the next one.
Okay, a 25-year-old patient is involved in a road traffic accident and sustains an avulsion injury of the upper two rods of the brachial plexus. Which of the following muscles is least likely to be affected?
That is like upper two roots of brachial. That is like C5, C6. Is that right? So that's like, it's Erb's Duchenne palsy. Okay, first let's see one by one. Okay, deltoid is supplied by which nerve?
Axillary.
Okay, that root value of that is what?
5, 6.
Yeah, so it's going to be affected, right? Deltoid is going to be affected. So we're going to remove that option. Okay, biceps brachii. Biceps brachii is supplied by what?
Coracobrachialis.
No, I mean the nerve that's supplied by biceps. Yes. Which nerve?
Musculocutaneous.
Okay, musculocutaneous. What's the nerve root value of that?
5, 6, 7.
It has 5 and 6, right? So biceps would be affected. Okay, biceps. What about brachialis? Also same nerve, right?
Same.
Also. Okay, what about supraspinatus? What's the nerve supply for that? Supraspinatus?
Supraspinatus. The same.
Suprascapular nerve, right? That's C5, C6 as well. Okay, so answer is like triceps, okay?
Triceps.
You can do it by exclusion. All right, let's see the next one.
Okay. 45-year-old patient develops communicating hydrocephalus following a spontaneous brachial hemorrhagia. Which part of the brain and cranial CSF pathway is primarily affected? Arachnoid villi, cerebral aqueduct, foramen Monro, fourth ventricle, lateral ventricles.
Okay, so what do you think, guys? What should be the answer? If someone have meningitis or have subarachnoid hemorrhage or whatever, and then they develop hydrocephaly afterwards, then yes, Muhammad, thank you. There is arachnoid villi, right? Because they will become blocked. If there is inflammation or hemorrhage in the subarachnoid space, they will become blocked. The arachnoid villi project into the superior sagittal sinus, and CSF is absorbed from there. Is that right? So it's also, they told you it's communicating hydrocephaly, so it's obvious. All right, let's see the next one. Yes, doctor.
24-year-old intravenous drug user presents with fever and right groin swelling. Imaging shows an abscess on the lateral aspect of the Psoas major muscle. Which of the following will be affected?
Yeah. So we have an abscess on the lateral aspect of psoas major muscle. And if that's the case, what function will be affected? What function will be affected? Zaid said it is option C, which is absence of sensation on the lateral aspect of the thigh. Anyone agree or disagree? Yes, that's good. So the nerve, of course, that is emerging from the lateral aspect of psoas major here, talking about the lateral cutaneous nerve of thigh, okay, or lateral cutaneous femoral nerve, and thus that's the function that is going to be affected. So it's very easy. This area anatomically is so important in the exam. They can ask you several questions. I can remember a few for you guys. Suppose they tell you, which of the following nerves emerge from the anterior aspect of psoas major muscle? So what's going to be the answer? Without reading options, what will be the answer? Yes, very nice. Okay, if they tell you what is the highest nerve that exit from the lateral aspect of this muscle, highest, most superior, iliohypogastric nerve. Okay, which one emerged from the medial aspect of the muscle? Turator nerve, nice. Which one lowest lateral? Lowest lateral, then what's that? Femoral nerve, right? Okay, let's see the next one.
Okay. 1-day-old infant is born with severe respiratory compromise. On examination, he has a scaphoid abdomen. Vowel sounds were audible on the left chest, and cardiac apex beat is displaced to the right side. Which of the following anomalies is most likely?
So that's like Bogdalic hernia. right? Poctalic hernia. Defect, right, in the diaphragm, posterolateral, usually to the left, more common than Morgagni. Why babies with this problem die? What's the usual cause of death? For what reason do they die? Of course, it's a very serious condition, right? Very serious. Very nice, Muhammad. Hypoxia due to pulmonary hypoplasia, right? Very excellent. The reason for that is failure of closure of the pleuroperitoneal canals. The pleuroperitoneal membrane, which should develop, did not develop. Thus, the pleuroperitoneal canals are open. We know that the lungs, embryologically, originate from the foregut tube, right? And then they grow into the pleuroperitoneal canals, and their growth itself closes the canal. So they think that pulmonary hypoplasia is the reason in the first place. You get me? It's not because the hernia compressed lung. They think nowadays that pulmonary hypoplasia is just one theory, not confirmed 100%, but it's there, right? So it's C, right? Option C, failure of closure of pleuroperitoneal canals. Okay, let's see the next one.
Okay. Which of the following structures do not pass through the internal acoustic meatus?
Okay, internal acoustic meatus. Yes, so, doctor, they're very nice. That is nervus spinosus. Which is what? What's that? What's nervus spinosus? Nervus intermedius is generally they call it the sensory root of facial nerve, okay? But it's not that accurate. It doesn't only contain sensory fibers. It does have sensory fibers, right? It have general somatic afferent and special afferent taste from the oral part of tongue, and general sensory afferent from some parts of the external ear, right? But it has one more thing. Nervus intermedius has one more thing. Anyone can tell me what other modality does nervus intermedius, famously called sensory root of facial nerve? What else does it have? Yeah. Yes. It has preganglionic parasympathetic nerve fibers that passes a nervus intermedius as well, which is going for what? It's going for what? Multiple glands, right? It's going multiple glands, lacrimal gland, small glands in the nose and paranasal sinuses, submandibular, sublingual, all of that. Okay. I have a question. It's kind of difficult, but centrally, the sensory special afferent of facial nerve carrying taste sensation from the anterior two-thirds of tongue, centrally in the brain or brainstem, that goes to which nucleus? Which is otherwise known as what? Going to a nucleus of tractus solitarius. Nucleus of tractus solitarius. Geniculate, it's not a nucleus, it's called geniculate ganglion, right? Yeah, the fibers relay there, but I mean in the brain centrally, okay? That's one thing. Okay, what about the parasympathetic fibers? Centrally, they're connected to what? Facial nerve parasympathetic fibers. inside. It's connected to which nucleus? They love that in the exam so much. Very nice, very excellent, superior salivatory nucleus. Okay. Okay, what about inferior salivatory nucleus? That gives, it's a part of which nerve? The inferior one is part of what? Nice, okay, very nice. Okay, coming back to my original question, what is this? Nervus spinosus is what? That's a small sensory branch of the mandibular nerve that, you know, mandibular nerve, it passes, it exits the skull through, if I can draw maxilla, okay, that's your beautiful maxilla. That's the back of, that's the piriform, you know, the nose, and that's your orbit. This is the pterygoid plate, right? Pterygomaxillary fissure. Under surface, a greater wing of sphenoid spine here. Then you have, that's what process? Mastoid. In the undersurface of sphenoid, there are two foramina, two, right? One is here and one is posterolateral to it. This one here is called foramen. Foramen? Foramen what? No, this one. This anteromedial foramen ovale, right? Okay, mandibular exit here. And it, just as it exits, is going to give a little, very tiny nerve called nervus spinosus. It comes back and re-enter the middle cranial fossa through this tiny foramen, which is foramen spinosum, along with the middle meningeal artery, and supply dura mater in the middle cranial fossa. That's nervus spinosus. Okay, all right. Moving on, let's see the next question. Yes, doctor?
58-year-old man with long-standing hypertension presents with sudden tearing chest pain radiating to the back. Imagine confirms an aortic dissection. Which of the following histological changes is most commonly associated with this condition?
Okay. Yes, cystic medial degeneration. Okay, fibrinoid necrosis is, does it happen in the aorta? Of course, they said hypertensive. We know fibrinoid necrosis associated with hypertension and vasculitis. Does it happen in aorta, or what do you think, guys? Fibrinoid necrosis. Because many people in the exam answered that, but it's not the correct answer. Fibrinoid necrosis is, yeah, it affects medium to small sized vessels, and it's not typical in large elastic vessels. All right, let's see the next one.
During a trauma laparotomy, a 50-year-old man is found to have profuse bleeding from the liver. The surgeon performs Pringles maneuver using a soft vascular clamp. Which of the following structures would be superior to the clamp?
Okay, something superior. So what's that? Yeah, caudate lobe, right? Which is which choanode segment is that? Segment 1. Very nice. That's segment 1, right? Okay, quadrate lobe is which segment? Yeah, you know, Italian people, they say quattro or something like that. Means 4. Right? So quadrate, quattro, 4. You can remember it like that. Okay, let's move to the next one.
During thyroglossal duct kiss excision after the skin and the platysma are opened, which layer should be dissected next?
Okay.
That's pretracheal.
Pretracheal fascia. Okay. Any other answer? So Dr. Sharab said it is brachial fascia. Okay, let me show you something. This is, I'm just going to say that's neck compartment. Okay, that's the neck in cross section, like axial. It has 4 compartments inside, right? Has 4 compartments. Anterior compartment called visceral compartment, 2 vascular compartments here, and 1 large one in the back. Okay. Now look, all of these compartments are having 1 layer of fascia surrounding all of them, called investing layer of deep cervical fascia. That's like all around, circumferentially. It also invests some muscles, like strap muscles. Okay. Then what's the name of the layer that covers this compartment? Which is the visceral compartment. What covers the visceral compartment? Pretracheal fascia, yes. And the vascular compartments are enclosed in the carotid sheath. And the one here on the back is enclosed by the prevertebral fascia. Okay. So it means that when you go after skin and platysma, which is enclosed in the superficial fascia, after that immediately is the investing layer of deep cervical fascia. Okay, investing layer. So it is option C. Okay, correct is option C. This option. Okay. Let's see the next one.
Which of the following nerves supplies the posterior aspect of the scrotum?
Yeah, that posterior aspect of scrotum. We know that the main thing that supplies it is the posterior perineal branches of pudendal nerve, but that's not in options. Also, I double checked that with the people who have been on that exam. All of them said it's not in options. So it means what other nerve, the question is simply telling you what other nerve that also supply posterior aspect of scrotum. Contributing to it, guys, is also that posterior femoral cutaneous nerve. Okay, option C. Posterior femoral cutaneous nerve. That also supplies posterior aspect of scrotum. What about anterior aspect? Front of scrotum. What supplies that? Yeah. Okay, good. Ilioinguinal and genital branch of genitofemoral. Okay, let's see the next one.
A 60-year-old male patient was found to have a tumor at the lower border of greater curvature of stomach. Which of the following vessels is located in this region?
So think of it like greater curve, lower part of greater curve. So it is to the right. So it is, as you guys said, right gastroepiploid. By the way, if anyone have any issue with any question or whatever it is, you can stop me at any moment. You can stop me and tell me what is that, okay? All right, let's see the next one.
A 3-year-old boy is referred because of an impalpable testis in the right scrotum. In which of the following position would it be described as an ectopic testis?
Is it B?
Yes, all right, ectopic testicle. Like it can be seen in most common location is where? Most common location of ectopic testicle.
Is it the superficial pouch? Superficial, like
Yes, so it's in the superficial inguinal pouch, which is
inguinal pouch? Yeah.
inguinal pouch. Superficial inguinal pouch, which is medial to the external ring. Okay. Other locations can be like root of penis, it can be in the perineum, that's rare. So yeah, out of these locations that they describe in the options, it is root of penis. Okay, let's keep looking, see the next one.
32-year-old woman presents with a thyroid nodule. Final aspiration cytology suggests papillary thyroid carcinoma. Which of the following nuclear features is most characteristic for the condition?
Okay. A nuclear feature which is characteristic of papillary thyroid carcinoma. Yeah, that's excellent. That is ground glass nuclei, or otherwise called, more famously called orphan Annie-eyed nuclei. Orphan Annie, right? Anyone have watched that cartoon? There is, I think there's a character called, I think there's a dog character, it's called Daddy Bucks or something like that. It's a very old cartoon. In which all the characters of that cartoon are drawn with empty eyes. You only see the white of the eye. There's no pupil or iris or anything. And the nuclei resemble that. So they call it orphan Annie-eyed nuclei, or less famous name, that's what came up in the exam, ground glass nuclei. There's also nuclear grooves. They also love to ask that in the exam. The nuclei have grooves. They call it nuclear grooves. Okay. Okay, let's see the next one.
Which of the following nerves is primarily responsible for the ejaculation?
That's B, pelvic slanking nerve.
Ejaculation, like ejaculation, which is it sympathetic or parasympathetic?
So it's sympathetic.
Yeah, so it is lumbar splanchnic nerve. Comes around like L1, L2 level, right? Synapse in the pre-aortic plexus. Then you have hypogastric nerves coming down to the inferior hypogastric plexus. And from there, that reaches the vascular structures of penis, right? Let's see the next one.
26-year-old male patient presents with a pleural abscess. To which of the following lymph node group it will likely to drain?
Okay. Pilonidal abscess. That happens where pilonidal abscess?
Like the natal cleft.
Natal cleft, okay, nice. So natal cleft drains where?
Superficial inguinal lymph node.
Which part?
This point is it medial?
Excellent, right? So look, guys, the midline structures in the lower back, natal cleft and perineum, they drain to the medial. Of course, we look, superficial inguinal lymph nodes are like T, okay? There are a group which is horizontal group, and there's like a vertical group, like a T, okay? The vertical group like generally drains superficial structures of the lower limb, skin, subcutaneous fascia, superficial structures of lower limb. Then the horizontal limb have two parts, a medial group and lateral group. Medial group drains what? It drains the shaft of the penis, the scrotum, the perineum, the natal cleft, all of these midline structures, right? Natal cleft, perineum, etc. The lateral group drains the lateral region of the buttocks. away from it's not at the natal cleft, it's lateral to that. Okay, that drains the buttock region. So it is B, right? Medial superficial inguinal lymph nodes. All right, let's see the next one.
Which of the following is true about bipolar diametry as compared to monopolar diametry? A. Current passes through the entire body from active to return electrolyte. B. Localized electrical field. C. It is mainly used for large tissue dissections. D. It requires a spare patient return ground plate. E. It has a high risk of collateral tissue damage.
Okay. Yeah, so we know that it's that bipolar, the electricity travel only between the rows of the instrument. So it is localized, right? Localized electric field. There's no need for patient return plate. There's no, by the way, if you have patient return plate or ground plate, earthing electrode, what is the minimum surface contact area needed for safe placement? Minimum amount of contact area between the patient return plate and the patient. What should be that area? It should be how much as minimum? Oh, that's very little, 5 to 7 cm, very little area of surface area of contact. So if the minimum is 70 centimeters square. 70 centimeters square is the minimum surface contact area required, the minimum. Okay, let's see the next one.
Which nerve road is tested by the triceps reflex?
Triceps reflex. Yeah, triceps reflex is what? Yes, doctor, what do you think? So, okay, let's revise reflexes. The biceps reflex is what and what? Biceps reflex?
It's C5, C6.
Okay, C5, C6, all right. Supinator reflex is how, what? What's the root value for that? Yeah, okay. And knee reflex is what?
It's L3, L4.
Okay, ankle reflex is what?
It's dorsiflexion is L5, S1.
No. Ankle reflex.
It's S1, S2. Yeah.
Okay. So then triceps is what? Yeah, why did you guys said C7, C6, C7, right? C7, C7 is the main one, then contribution from C8. Okay, I think I made you very tired, doctor. You read a lot. I'm sorry. Anyone would like to take over? Maybe give the doctor a rest a little bit? Anyone would like to take over reading questions? Sure, yes, great. Can you please read this one?
Hello, can you hear me?
Yeah, I can hear you.
Okay. A 28-year-old long distance runner presents with medial knee pain, worse when walking uphill and during activity. On examination, there is soft cystic swelling located below the medial joint line. This swelling is most closely related to which structure? medial head of gastrocnemius, semitendinosus, semimembranosus, gracilis sartorius.
No.
Is it a Baker cyst?
What a question. Okay, let me just focus on it. It's the first time for me to see it. 28-year-old long distance runner. Okay, present with medial knee pain, worse walking uphill. That's going with pes ansernis walking uphill, isn't it? On examination, soft cystic swelling below the medial joint line. That's not Baker's cyst. Okay, it's not Baker's cyst because Baker's cyst is usually posterior and it's at the level of the joint line. It's medial, of course, because it's the gastrocnemius semimembranosus bursa, right? That's Baker's cyst. But if we consider Baker's cyst, it will never be right because there are two options which are right. You agree, guys?
Yes. Is it some kind of bursitis? There's a bursa located underneath pes anserinus, I think.
I agree. It's pes anserinus bursitis. So I know already that in pes anserinus bursitis, which tendon is usually responsible for that? High strain, high stress on which tendon?
Can you repeat the question?
In pes anserinus bursitis.
Actually, there are three tendons. Actually, there are three that came together. The peasant.
Yeah, but which one of them is responsible for that condition mostly? Which one applies more stress on the bursa, on the pes anserinus, sorry? Which one applies greatest stress, especially in runners?
Semitendinosus?
Semitendinosus. Yeah, so it's semitendin. You know what? If you consider Baker's cyst, there are two correct answers. You cannot know if you
Yeah, I
consider
know.
Baker's cyst, right? Because Baker's cyst is just simply what the
The
bursa
popliteal
between,
fossa, yeah.
yeah, and it's the bursa between semimembranosus and medial head gastrocnemius. So you can't answer that, right?
Yeah,
Okay.
yeah, exactly.
So it's semitendinosus. You agree, guys? Agree with me?
Yes.
Okay. Let's see the next one.
A patient is scheduled for elective surgery. He is on aspirin and dipyridamole. When to stop dipyridamole pre-operatively? 5 days?
I think it's 10.
Dipyridamole. They want dipyridamole. Yeah, 2 days. Dipyridamole, 2 days. Stop 2 days before the surgery. They want dipyridamole, not aspirin. Okay. Okay. Aspirin, you stop it how much before surgery? Aspirin.
Aspirin, we don't stop, I think.
If you have to stop it, if you have to.
5 days.
Like 6 hours or 5 7 days. Okay.
Yeah, okay. 5 to 7 days. Although 7 days is usually the number quoted. What about clopidogrel? You stop that when?
It's 7 days.
No, 10 days.
10 days or 10 days.
Yeah. Okay. For example, metformin, you stop it when?
Like the omit the morning dose, like something. Like the
One
last day,
level.
the last night before the surgery, like 12 hours before the surgery.
Yeah. And what about gliflozins? The SGLT1 inhibitors, you stop them when?
SGLT2 inhibitors, I think. I think gliflozins.
Yeah.
I don't remember that.
3 days. Right?
3 days. Okay.
Okay. Let's see the next one.
Hydroxycholecalciferol is produced in which of the following sites? Liver?
Yeah. So liver, right? Dihydroxycocalciferol or 125 dihydroxy vitamin D is produced in kidney. Let's see the next one.
Okay. A 65-year-old patient with history of angina undergoes elective uncomplicated Inguinal hernia repair. Postoperatively, he becomes hypotensive, developed tachycardia, raised JVP. What's the diagnosis? Obstructive? Is it obstructive?
Obstructive shock because of raised JVP.
Yeah.
Okay, what about this one? He has like prior history of ischemic heart disease.
It wouldn't give you. Oh, yeah, it can give you JVP, raised JVP, but then patient will be in heart failure.
Mm-hmm. Okay, so we have patient that has a history of angina, meaning like he have pre-existing ischemic heart disease, and then he had a surgery which, for example, this surgery is inguinal hernia, and it, of course, that's not going to lead to like pneumothorax or something like obstructive shock, right? So it's going with cardiogenic, isn't it?
Yeah.
Okay, let's see the next one.
A 10-year-old presents with recurrent chest infections and abdominal pain. His aunt has a history of meconium ileus. Which channel is impaired in this condition? Chloride channel.
Excellent, yeah. So it is cystic fibrosis. Do you agree, guys? Cystic fibrosis. Mutation CFTR, autosomal recessive disease, right? You don't have to know the mechanism, but the bottom line is that chloride channels are defective, but you don't have to know the mechanism for that. Chloride channel. All right, let's see the next one.
A 60-year-old man suffers a head injury. He is initially stable but develops progressive headache and confusion 2 weeks later. A CT scan shows a crescent-shaped extra axial collection over the cerebral hemisphere. What is most likely diagnosis? It's chronic subdural.
Okay, acute versus, so it's subdural, but it's crescent shape, you know. Why are you guys saying subarachnoid? Am I missing something? That's not subarachnoid, right? It's extra-axial crescent shape. So that's subdural. Okay, is it acute or chronic? 2 weeks, does it qualify to become chronic?
It's acute.
Yeah, it's actually subacute, but it's not in options. But it's definitely not acute. It's not acute, right? So look, acute is up to 3 days. Subacute is 3 days to 3 weeks. Chronic is more than 3 weeks. And you can also look at CT criteria as well. You can know if it's acute or chronic just on CT, okay? Because based on the density, but in acute, it is hyperdense, right? In chronic, it's iso or hypodense collection. How are we going to answer that? It was reported to me like that, and they didn't tell me like in options there was subacute. We have to get as chronic. Would you agree? Anyway, remember the timings because things can differ in the exam. Background noise, it's not on my side, I think. Very quiet here. Okay, let's see the next question.
A patient develops avascular necrosis of scaphoid bone. Which joint is most affected?
Okay.
Is it C?
Scapotrapezial joint.
Yeah, it's I think C.
Okay. Okay, let's think about it logically. Scaphoid, AVN usually, which part of scaphoid?
The proximal part.
Okay, so the proximal part of scaphoid articulate with what?
Radius.
Well, what's the answer?
The radius to light process.
Yeah.
Oh,
So radius scaphoid joint is mostly affected. Also, scapholunate joint is affected, but the area of contact and the stresses going through the scapholunate is much less compared to that going through the radius scaphoid, because that forms the rest joint, right? So more stresses going through it, so more likely to be damaged or mostly affected. Radius scaphoid. Okay, let's move to the next one.
A 26-year-old poliomyelitis patient presents with foot drop. Paralysis of which of the following muscles is most likely responsible for this deformity? C.
Yeah, that's easy, right? Okay. Let's see the next one.
A 32-year-old presents after a head trauma. On arrival, his GCS is 15, but over the next hour, it suddenly drops to 7. What is the most likely diagnosis?
Like sudden deterioration.
A. It's A.
He was initially okay, but then there's a sudden A, right? Epidural hematoma. Subdural tend to have more time, not sudden. Traumatic subarachnoid usually bad from the beginning. Diffuse axonal injury bad from the beginning, right? There's no improvement, then becomes bad. It's already bad. Concussion, it's bad, then they improve. They don't come back to become, it doesn't deteriorate later, right? Okay.
A patient receives epidural analgesia. Which type of nerve fibers is primarily targeted to achieve pain relief? C.
This A delta.
What?
C
Like A
fibers?
delta. The A delta fibers.
Yeah, I get it, but I think both options are correct, though. Like A delta transmit fast pain, isn't it? Or sharp pain, A delta fibers. And C fibers, they also transmit pain sensation. Well, that's a great question. Last one in pathway, maybe. A alpha, no, I don't agree with A alpha because they won't achieve pain relief, right? A alpha, no pain. Okay, I want you to take a screenshot for that so we can make sure. I would have answered C fibers, but we will check literature. I'm going to give you only confirmative answers.
Okay, so
Okay.
I searched for it. It says that C fibers are more sensitive to local anesthetics because they're blocked earlier than A delta fibers
I
because they are
agree.
unmyelinated.
Yeah, I totally agree with that fact. But it doesn't make it an answer because the thing that we need is pain relief, not the fibers which are targeted earlier or late. The objective is pain relief. So we know that C fiber and A delta fiber both transmit pain, but which one, when blocked, achieve the greatest effect? That's the question. That's the real question. Which one, when blocked, will achieve the greatest effect? Anyone have an idea? Okay, so we're going to keep that aside, review the literature, make sure, then we're going to come back to it. Okay, let's see the next one. Yes, doctor, you with me? For some reason, I can't hear you. Maybe your mic. Hello? Can you guys hear her, or just me? Because I can't hear her from my side. No? Okay. We can't hear you, doctor. Maybe you can unmute yourself, then try again. Okay, maybe she having an issue on her side. Okay, I'm going to read that one for you guys. A 48-year-old female complains of numbness over the medial aspect of the right leg following varicose vein surgery. Which nerve root value is responsible for supplying this area, which is medial leg? Okay, what supplies medial leg?
This L4?
Yeah, L4, right? Simple question, L4. Okay. This one is telling you what? It's saying a 35-year-old primey present with history of labor, which was prolonged difficult labor. Okay. There's also instrumental assisted vaginal delivery. And then she complains of continuous dribbling of urine from the vagina. Then what's the diagnosis then? Don't look at options, just make up the diagnosis. Prolonged labor, continuous incontinence equals what? Immediately, that should be the answer. Yeah. Fistula, right? Vesicovaginal fistula. Vesicovaginal fistula. It's just simply baby's head, the compression created causes necrosis, pressure necrosis, and then a fistulous communication is there. Okay, as simple as that. It leads to continuous incontinence, not intermittent, as they said, continuous dribbling. Okay. Question 33 is saying, which of the following nephron segments is primarily responsible for water reabsorption? Among these options, which one takes most water?
Is it descending loop of Henle?
No.
Most water.
No.
I know I start with the PCT, but I was thinking
70% of the filtered fluid is taken back again by PCT. Okay, but isoosmotic. It's isoosmotic because both fluids and solutes are taken in equimolar amounts. Not like, for example, the ascending limb of Henle's loop. It's not isoosmotic, right? Because it's taking only solutes and no water. That's called the diluting segment of the nephron. It's essentially impermeable to water, by the way. So it doesn't essentially absorb anything. But proximal convoluted tubule absorbs 70% of that. It's the main part of the nephron which absorbs water, which is obligatory water reabsorption. You know why it's obligatory? It will always occur irrespective of the state of the body. But the distal part of the nephron, that's facultatory water reabsorption, means it can be adjusted. This amount can be adjusted because it's aldosterone sensitive and ADH sensitive. Is that right? Okay, let's keep going. What about that question? A 60-year-old man with esophageal carcinoma underwent Ivor-Louis esophagectomy and gastric conduit anastomosis with intraoperative feeding jejunostomy. Which artery is the main blood supply to the gastric conduit? Famous question.
Is it right gastroepiploic artery?
Thank you. Yeah, thank you very much. It's right gastroepiploic. Right? All of the others are usually sacrificed in the operation. But right gastroepiploic artery and vein needs to be preserved. It becomes the main blood supply to the intrathoracic stomach. This anastomosis, esophagogastric anastomosis that is created, in your opinion, what is the most important layer that needs to be opposed and sutured? in creating this anastomosis, which should prevent anastomotic breakdown. Which layer is more important for you? Is it the muscle layer, the mucosa, the submucosa? What exactly? What do you think? Let me rephrase the question. The question is, which layer that prevent anastomotic breakdown? Not which layer that prevent leak. That's different, okay? Yes, it's submucosa, right?
It's
The submucosa, yeah, that can be a question. It came in previous exam. Submucosa, remember. I will give you something simple to remember. Submucosa, right? Glues and serosa seals. Meaning what? Meaning that presence of serosa layer is important for any anastomosis. I'm talking in general. Because serosa heals very quickly within hours and seals the area. So it prevents leak. But submucosa give the strength. Give the strength. Which question, Muhammad? Is it this one you mean? Question 34? Okay, I'll come back to it. Let me just tell you this important information. I want you to write it down, guys. What prevent leak? Serosa. What prevent anastomotic breakdown? Submucosa. This is why if you have an anastomosis after low anterior resection rectum, that is below the peritoneal reflection of the rectum, here there's no serosa. So such anastomosis leaks. So it means we need to cover it. Covering stoma needs to be there for that. You get that? But if you have iliotransverse anastomosis or small bowel anastomosis, you have serosa. So it means you don't need a covering stoma for that. You don't need to cover that anastomosis. Even you don't need to prepare the patient mechanical. You don't need mechanical bowel preparation. Why the answer is C. That's the surgical technique. Look, stomach is in the abdomen. In that operation, we resect thoracic esophagus and we have a gap. This gap is usually bridged how? We bring the stomach to the chest. For that, you need to mobilize the stomach. You need to cut most of the ligamentous and peritoneal attachments of the stomach to bring it up the chest. That's called gastric conduit. For that, you need to sacrifice vessels. So most of the vessels are actually sacrificed, like the short gastric vessels are sacrificed, etc. Except this one, right gastroepiploic, because technically this vessel you can bring the stomach up with it, just for technical reasons. In Bailey and Loves, they tell you the artery is equally important as the vein in this case. So it means in the operation you must be absolutely sure that right gastroepiploic artery and vein are intact by the end of the operation. If they're compromised, the anastomosis will become compromised. Okay, let's see this one. Question 35. Yes, doctor, if you can continue, that will be great. Dr. Zulika, if it's possible, if you can hear me. Maybe there's an issue with the microphone. Anyone else want to carry out? We're going to have a break soon, but anyone else want to carry out?
Okay, I will do it.
Thank you very much. Okay, let's see this one.
They say a 75-year-old farmer has a BCC resected from his face, and what is the most important prognostic indicator? The prognosis is the Breslow invasion, but I know, but...
Oh, you're talking about malignant melanoma there.
Oh, sorry, yeah.
Basal cell.
So it's the complete excision of the basal cell.
Yeah. Completeness of excision is the most important prognostic factor. Okay. In basal cell. Okay, let's see this one.
They say a 40-year-old patient present with a solitary swelling in the front of the neck, and the ultrasound showed the solitary thyroid nodule. Blood test revealed high T3, T4. Which of the following is the most appropriate next investigation? It's high T3, T4 as solitary. I think it's a FNAC.
You want to see the question again?
Yeah, sure.
Okay.
Solitary nodule is there. This is high T3, T4. So most probably it's like something like what is the next investigation they're asking? Can you see? Oh, just next investigation they're saying. So why not, sir? FNAC here.
You answer D.
Yeah, I'm thinking of D.
Fine needle aspiration cytology. Okay. All right. If you look Bailey and Loves, if you like to read that, this book, by the way, it's okay. It's nice. It's okay, but for exam purpose, I don't recommend that. I don't recommend you reading from Bailey as a main source just for the exam. But for work and just to have more knowledge, it's okay. It's a nice book. But anyway, they tell you what? They tell you if there is toxicity, you can look it up, okay? Toxicity and nodularity. The nodule in the gland and patient have toxic manifestation. You need thyroid scintigraphy or scan. Either thyroid scintigraphy or radioiodine scan. Why? Why is that case? Because you want to know, is it the nodule which is active, hot nodule, or is it the internodular tissue that is active? Because that will change management, okay? That's going to change management. Because if it's like toxic adenoma, of course, you don't have to remove the entire gland. If it's toxic adenoma, you have two options, either lobectomy or you can use radioiodine ablation, right? But if it's internodular tissue that is active, which is toxic multinodular goiter, in that case, lobectomy may not suffice, okay? Most of the cases treated with total thyroidectomy or near total. So remember, toxicity plus nodularity equals scan. Always remember that. Okay.
Systemic we do in the parathyroid.
Yeah, systemic different story. Systemic scan, except in one. If someone can answer that for me, I'll be very impressed. In which situation would you use systemic scan to image thyroid gland? We know systemic for parathyroid, but if you want to use it for thyroid, you use it for what?
Like some hyperplasia?
What? Come again?
Medullary carcinoma?
No.
It's not in parathyroid. Is it a parathyroid hyperplasia?
I mean, look guys, systemic scan is used for, it's the best scan that you can use for parathyroid glands. Why? Because parathyroid glands, there are cells there called oxyphil cells, which are very rich in mitochondria. When you give systemic scan to them, this actually, it is taken up by any tissue with high mitochondrial count. The higher the mitochondria in the cells, the higher it will show, okay? So it means which thyroid lesion, you need to think now, which thyroid lesion that contain large amount of mitochondria and thus appear on systemic. You get the question?
Yeah.
That's the question. So anyone knows of any such lesion? Hürthle cell follicular carcinoma, right? It's a subtype of follicular carcinoma called Hürthle cell. It's of poor prognosis and it shows very well on systemic as well. In some situation, there's also Hürthle cell adenoma and patient already known to have it, okay? But also have parathyroid lesion and we need systemic for that. But the image will be superimposed, thyroid will be superimposed on it. So it means we can do thyroid scan and systemic and digitally subtract that from the systemic image, okay? But I don't think they will ask you that in the exam. That's too advanced. All right, let's see the next one.
They say during the examination or reduction of the indirect inguinal hernia, the external pressure is applied to control the hernia. The pressure is typically applied at which point? So they ask. So that's the. They say the superficial inguinal. If we say so, it's like a midway between the ASIS and the pubic tubercle.
Yeah. So essentially, they're asking you for what? For the
Midpoint
surface
of the
anatomy of
inguinal.
deep ring, right? Is that right? Deep ring. Because that's how to control the hernia. You need to apply indirect hernia. You apply pressure over there. So it's midway between anterior superior spine and pubic tubercle, which is.
And this is what they say.
What?
And this is what they say. The midpoint of the inguinal.
Yeah, midpoint of inguinal
ligament.
ligament. Yes, very nice. Okay. What about this one? They can ask you also this one, which is mid-inguinal point. That's midway between the spine and the symphysis. That's for?
Femoral artery sensation, like pulsation.
Okay. Let's see the next one.
Patient present with the cement in the eye. What is the best immediate management? Is the irrigation with water? Use the alkalization agent as a, so it's A, right? Irrigate with the water.
Irrigate with water, right? That's the first line management, at least for 30 minutes. Continuous irrigation of water using a special catheter, palpebral catheter that can be placed, and you continuously irrigate the eye. Using neutralizing cement is alkaline. So some people came up with an idea that was a long time ago. They said, let's just add acid to that. So it will be neutralized. But this is an exothermic reaction, generates heat and add more damage. So it was a very bad idea. Okay, so no neutralizing agents, just water, irrigation with water. Oh, let's see this one.
There's a 58-year-old female present with the left hip pain. The X-ray of the hip is done.
That's what
the head. So the head is like a bit. Following the diagnosis.
Okay, I'll see the options.
Can you see the options here? It's osteoarthritis, avian, is septic arthritis, intercapsular fracture. I think it's B.
Yeah, it's avian, right? Because
you can see the all the opacification there.
Opacification, the femoral head looks irregular, so that's like AVN. Okay.
G.
Let's see next one.
A 29-year-old female complains of dyspareunia and the tender inguinal swelling, which of the following the expected site of pathology? So it's dyspareunia and tender inguinal swelling there. Is cervix? Dyspareunia. Or it's Philippine tube. Dyspareunia and then tender. I think it's type of STD, and I think this is fallopian tube.
But that doesn't drain to inguinal lymph node.
But then we can go like it's upper vagina, yeah.
No, upper vagina drain to internal iliac.
So super free. Is the iliac? So that is not.
Think about something. I would simplify. Out of these options, which structure drain to inguinal lymph nodes, whether deep or superficial?
The anus is there in the superficial.
Yeah. Okay. So STDs. In one question, one of the options was vulva. So that was very easy, right? Because vulva drain to superficial inguinal lymph node, cause dyspareunia. You know the deal. But in this exam, my students told me that this option was not there. Vulva was not in the options. Anus was there. Okay. And yes, it can still present with dyspareunia, even STD there. And it can affect the anal region as well, right?
Mm.
So it makes sense. Okay, let's see the next one.
Okay. A 15-year-old boy present with a 3-month history of the unilateral boy with the unilateral breast swelling, which is the following the cause of breast swelling is, I think there's like a gynecomastia and there's a physiological.
Yeah, this
Unilateral
age
breast.
boy, even unilateral, even if it's unilateral, it can still be, and the most common cause is physiological.
Yeah, physiological gynecomastia.
Around puberty, that can happen, right? Okay,
Yeah.
let's take one more question, and then we're gonna have a break. Let's see this one.
This 79-year-old man present with a painless ulcer on the lower lip, and there's no lymph node enlargement. Which of the following is the most likely diagnosis? The lower lip is there. It's painless.
Looks malignant. Okay.
No, so A will not be there. It's no lymph node. C?
Yeah, so C, basal cell cancer is the most common cutaneous cancer. In elderly, it happens. Typical locations, unexposed area. And no lymph node enlargement, because we know it doesn't. Almost never. It's there, very rare exceptions, but almost never metastasizes. It's locally invasive and everything, but doesn't metastasize. All right, guys. Hope you enjoyed that. We will have a break, and then we will come back at 6:30 GMT. 6:30 GMT. Another link, not this link, another link will be posted on the group. Okay.
A 55-year-old patient undergoes colonoscopy, which shows brown-black pigmentation of colonic mucosa. Which of the following is most likely cause? Iron supplementation.
Okay. So it is brown-black pigmentation of the colonic mucosa itself. What do you think? Iron pigmentation doesn't cause an obvious black pigmentation of the colonic mucosa. If you say black pigmentation, so, or brown to black pigmentation, there's a condition, guys. There's a condition which is associated with consumption of a type of laxatives called anthraquinolones. These type of laxative drugs called anthraquinolones laxatives, right? An example of which is Senna. There are many other examples, but Senna is a famous example for that. It's kind of used in traditional fashion, you get me? And chronic use of these laxatives causes pigmentations, blackish pigmentations in the mucosa of the colon especially. This condition is called what? The name of the condition in which there is it results from the excessive chronic use of anthraquinolones. It's called melanosis coli. Okay, it's called
Melanosis.
Yeah, melanosis coli. Although the name is very misleading because it's called melanosis, but there is no melanin there. No melanin is deposited. So they may ask you in the exam, what kind of thing that is deposited? What's the name of the substance that is deposited? Right. It's called lipofuscin pigment. Lipofuscin pigment, okay? All right. It's harmless. You stop the laxative and it will go away. Okay. Let's see the next question.
A 40-year-old patient presents with abdominal discomfort. Phagogastroduodenoscopy reveals a well-circumscribed mass in the body of stomach with intact mucosa. Which of the following is the most likely diagnosis? Gastric adenocarcinoma, lymphoma. Can I see the other options?
Yeah, are they visible?
What are the other options?
Gastrointestinal stromal tumor, fundic gland polyp, or none of the above? Do you want to see the question again? Ask the question again. So, a 40-year-old, like middle-aged patient, and I'm approaching 40s. I don't consider myself middle-aged. I still feel young. I think they should recategorize age groups. Middle age should start like from 70, right? 70 onward is middle age. Anyway, so OCD is showing a mass in the body of the stomach. In the body of the stomach. And the mucosa on top of that mass is intact.
It's just C.
Yeah, gastrointestinal stromal tumor, very, very important topic in the exam. I would like just to tell you some of the high yield notes about it. First high yield note that you should know about this thing is that it originates from interstitial cells of Gastric, right? So the origin of this tumor are specific type of cells called cells of Gastric or interstitial cells of Gastric. These cells are basically pacemakers for the gastrointestinal system. Those are the ones that originate peristaltic movements, right? Those are called interstitial cells of Gastric. That's first important note. Second important note, these type of tumors are linked to an important mutation in called CKET mutation, or otherwise called CD117. This is actually pathognomonic mutation, meaning that it's essentially present in all GIST tumors. That's the second important point. Third important point is that the drug of choice to use, especially when you want like preoperative preparation or in metastatic GIST tumors, the drug of choice to use is called imatinib, right? It's tyrosine kinase inhibitor called imatinib. Write this down, very important to know. Another important note about GIST tumors is that they're kind of gray tumors, you get me? They're not frankly malignant, they're not frankly benign. They can have a spectrum. They may be very benign, they may be very malignant. So how to know if they are malignant? Number one, if they're metastatic, they're malignant. Number two, if they are over 5 centimeters in size, they are likely to be malignant. Okay? These are the two most important things that indicate malignant GIST. Another important note, GIST tumor may occur in any part of the gastrointestinal system, but small bowel GIST tumors have very high chance of being malignant. Although gastric GIST have less chance of being malignant, so intestinal GIST are more likely to be malignant. That's important. Final note is that the commonest location is body of stomach. And endoscopically, they look like just with circumscribed mass. Sometimes there's central umbilication, that you find a mass like this, with the top of the mass have necrosis and looks dipped like an umbilicus. So they call it central umbilication. That's also very characteristic endoscopic finding. Okay, that's what's important for exam. Let's move to the next one.
I have a question.
Yeah.
So, what type of surgery do we do? Like, do we remove the stomach?
I think we do the veg resection, something called veg resection.
Yeah.
Okay, thanks. Okay, next question 45. 29-year-old female complains of periareolar discharge following nipple piercing. Which of the following is the most likely cause? Mm, periareolar discharge. D?
Yeah, D, mammary duct fistula. It is a famous complication of nipple piercing. Just it happens that the duct trauma from the piercing itself can create fistula. And because of the duct trauma and ongoing inflammation, there may be discharge through the fistula's opening. Okay, let's move.
Question 46. Other than internal iliac lymph nodes, imaging. Oh, okay. Lymphatic drainage of uterine cervix is to which of the following lymph nodes?
Mm-hmm.
I think it's A.
Yeah, it's A. So uterine cervix of uterus, it drains to internal iliac lymph nodes, but also external nodes, external iliac nodes and sacral nodes. The fundus of the uterus, by the way, is the only part of the uterus which have drainage to the superficial inguinal lymph nodes. Okay, that's the only part of the uterus which drains there. But the body also drains to internal and external nodes, fallopian tubes. Some part of them also drain with the ovaries to para-aortic nodes. There's a file, all lymphatic drainage in every part, you will find it there. Okay, let's see the next question.
I think
Question
the
40.
sir the fundus of the uterus it spread to the para-aortic lymph node.
Yeah,
No.
that's what I was also.
So let me tell you, the fundus, you said what nodes?
The para-aortic lymph node.
Para-aortic.
Para-aortic nodes. Well, what I know is that the fundus of the uterus drains along the round ligament of the uterus to the inguinal lymph nodes, but let's make sure. Wait a minute.
Yeah, it's minor, but it's clinically important.
Yeah, minor drainage is not the main pathway.
Main is para-aortic.
Yes, that's correct. So minor pathway, superficial inguinal, and para-aortic nodes is along the ovarian vessels also to para-aortic. Nice. Okay. Okay, let's move to this question.
Question 47. A patient undergoes MRI for back pain. Imaging shows fat protruding into the space below the 12th rib. What forms the medial border of this triangle? It's
Okay.
superior lumbar triangle. Quadratus lumborum.
Excellent. That's a superior lumbar triangle, or also called Grenfell triangle, right? Grenfell triangle or superior lumbar triangle. Superior border is 12th rib. Medial border is quadratus lumborum. Lateral border is what?
Internal oblique.
Nice. Internal oblique. Floor is what?
Floor is also internal oblique.
No.
Transversalis fascia.
Transversalis fascia. That's important in the exam. It came in May 2024. The floor is transversalis fascia. Roof is?
The 12th rib?
Okay. What about inferior lumbar triangle, also called triangle of Petit? Inferior lumbar triangle. What are the borders? Anyone can tell me that?
Latissimus dorsi.
It's medially by the latissimus dorsi, laterally by the external oblique,
External
and
oblique.
inferiorly by the iliac crest.
And the
Yes.
floor?
Transverse talus fascia.
No.
Internal
Internal oblique.
oblique.
Yeah, internal oblique. Okay. Let's see the next one.
Which of question 48? Which of the following are correct components of what?
Instilla gel.
Instilla gel. I don't know.
Okay, so Instilla gel is used for urethral catheterization. Most common use, right? It's just a gel that have an anesthetic and have an antiseptic. Okay, so it contains lidocaine and chlorhexidine in it. So it's option A. Instilla gel contains lidocaine and chlorhexidine. What about IMLA cream? That came in one exam. IMLA cream, what's the component of that? IMLA stands for eutactic mixture of local anesthetics. Eutactic mixture of local anesthetics. So it's composed of what and what? IMLA cream? Commonly used for many things. Like, for example, some people use it for circumcision, some people use it for cutaneous lesions. You know, it's very famous. IMLA cream is composed of lidocaine and prilocaine. IMLA cream has lidocaine plus prilocaine. You know what's the idea behind mixing them? The combination of lidocaine and prilocaine, it lowers the melting point of the individual anesthetic, which means that these two drugs can exist in oil form at room temperature, which improves skin penetration. That's why they are more effective as combination together. You get me? That's called IMLA. So Instilla gel, remember that's the two most common things they come in the exam. Instilla gel, lidocaine, chlorhexidine. IMLA, lidocaine, prilocaine. Okay? All right, let's see the next one.
Question 49. A patient presents after a blunt injury to buttocks and now unable to extend the hip. Which of the following muscles most likely affected? Gluteus maximus.
Yeah, so gluteus maximus, we know it extends hip. Easy question. Let's see the next one.
Question 50. Which of the following is consequence of prolonged NG aspiration? Low plasma chloride.
Excellent. We know it causes hypochloremic, hypokalemic, metabolic alkalosis with paradoxic aciduria. Right, that story that we always talk about. So it's low plasma chloride. Answer is low plasma chloride. Is that right, guys? Okay.
Question 51. A patient undergoes low anterior resection for carcinoma of low rectum. Which artery is typically ligated to achieve adequate oncological resection? Inferior rectum?
Is it E?
Sigmoidal artery. Anything else? Any other answer?
Superior rectal.
Well, there's a man that goes by the name Hohenberger, right? It's a funny name, but it's a nice name. It's called what? Hohenberger. Okay. This man basically made a revolution in oncologic resection of the colon, colonic resections. What did he say? He said that when you want to resect part of the colon as oncological resection for cancer, the vessel supplying this area have to be ligate, high ligation, flush at its origin. So let me tell you an example. For example, if someone have carcinoma of the descending colon, what supplies descending colon? Left colic. Left colic comes from what? IMA, right? Inferior mesenteric. So Hohenberger tells us that you have to ligate the inferior mesenteric flush at its origin from the aorta. Why he's saying that? To include all of the lymphatics that are coming. Of course, lymphatics travel along with the blood vessels. So if you ligate that blood vessel, you ensure that you've ligated all of the lymphatic basin. You get that? Okay, so that's the point. That's the point for the question. So resection for the colon, rectal resection, we have high anterior, low anterior, and AP resection, abdominal cranial resection. In these vary, if there is rectal carcinoma, you want to do low anterior resection, there are two options. The classic Hohenberger technique tells you to ligate IMA. Well, is it safe? Yes, it's safe. It's safe to ligate IMA because there are, as we discussed in previous sessions, two alternative pathways, right? Which are what? Marginal artery of Drummond's and arc of Ryolan. You remember that, guys? We discussed that. So arc of Ryolan and artery of Drummond, marginal artery of Drummond. Is that right? So it's safe to ligate IMA in most of the cases. The other variety is to ligate superior rectal artery. That's also described for low anterior resection. So answer for that is superior rectal artery. Deal? Okay, let's read the next one.
Question 52. 65-year-old woman has undergone mastectomy and axillary lymph node clearance for 3 cm diameter ER negative, PR negative, HER2 positive tumor. 5 out of 14 axillary lymph nodes contain metastatic disease. Which of the following adjuvant systemic therapies would be most appropriate for her?
Okay.
D
Take your time.
or C?
Yeah. Breast cancer, very important topic in exam. Do you guys want to discuss the treatment of breast cancer? Do you feel like wanting to discuss that?
Is it C?
Yeah. What, doctor?
Like this is HER2 positive tumor, so I was saying, is it C?
Okay, why not Herceptin alone then?
Because it's the lymph node is positive, that's why I was thinking.
Yeah, good. So I'll just tell you the high yield notes about management of breast carcinoma. First thing I would like to talk about is neoadjuvant therapy. Neoadjuvant therapy. Neoadjuvant therapy. I'll try to summarize as much as possible, okay? Neoadjuvant. Okay. Neoadjuvant chemotherapy or neoadjuvant targeted therapy or neoadjuvant hormonal therapy means that these are therapies given prior to the surgery with the aim of downsizing the disease, making it smaller. Okay? And improving the success rate eventually of the operation. So what are the indication of giving neoadjuvant therapy in general? Write with me. Number one, let's write here. Number one, any locally advanced cancer, locally advanced. What's the definition of locally advanced? It means T3 or T4. Someone will say, oh, T4 is operable? Yes. Nowadays, in our era, it's still operable, okay? But you have to give new adjuvant. Second reason is, you know, breast cancer surgery can be of two types. Now, either patty mastectomy, removal of the entire breast, or a category of therapy called breast conservation therapy. Breast conservation therapy, which means what? Breast conservation therapy, which means local resection of the tumor, local resection, plus radiotherapy. Look, radiotherapy always there. If you want to do breast conservation therapy, it's standard part, because if you do not do radiotherapy, recurrence, highly unacceptable, very high recurrence rate. So what does that mean for us? Anyone with a contraindication to radiotherapy cannot have that. For example, those with SLE, they can have flare because of radiotherapy. Those with severe orthopnea, they cannot sit for a long time for radiotherapy. You get that, right? So it means breast conservation therapy can be done, generally speaking, if the tumor is small in relation to the size of the breast. So if a female have large breast and tiny tumor, she's a candidate for breast conservation therapy. Some females are initially not candidates because the tumor is very large, but they wish not to have mastectomy. They want to preserve the breast. So that's the second indication. If tumor too large for breast conservation therapy. So you give neoadjuvant to make the tumor smaller so that you can remove it without removing the breast. That's second indication for neoadjuvant. Third indication for neoadjuvant, any HER2 new positive tumor, HER2 new positive, neoadjuvant targeted therapy. Fourth indication, triple negative. That's an indication on its own, triple negative, to give neoadjuvant chemotherapy. Even if it's early tumor, you still give it. Last indication is for premenopausal women, which generally less than 50 years. Okay. That's neoadjuvant indications, okay? That's the important notes about it. Now we move to surgery, surgical treatment. Okay. We can divide surgical treatment into two parts. Let's remove that. Okay. We can divide surgical treatment into two parts. Okay. So surgical treatment. We divide that into two parts. Surgery for early breast cancer, which is T1 or T2 with no nodes or N1. And advanced. Okay, let's start with early first. Early T1 means what? T1 means less than 2 cm. 2 cm or less. T2 means between 2 and 5 cm. Okay? What are the options for that? Two big options. Mastectomy or patty mastectomy. Patty mastectomy, or also called modified radical mastectomy. Second option is breast conservation therapy. Okay, what about patty mastectomy? Patty mastectomy means what? They like to ask that in the exam. It means removal of the entire breast down to pectoralis fascia, without removal of the pectoralis fascia or pectoralis muscle. That also includes the axillary tail of the breasts, okay? That is called patty mastectomy. The Hallstatt, or that is radical, no longer done nowadays. It's very aggressive. Okay, so when should we consider mastectomy as compared to breast conservation therapy? When should we consider mastectomy in favor of breast conservation therapy? Anyone knows that? When she said like, oh, no, that patient with early breast cancer, I think she should go for mastectomy. She's not a candidate for breast conservation.
If it is the multicentric lesion, cancer,
Good.
and more than
Good.
4 centimeter of the size of the tumor.
That's objective. That's objective.
This
You can say,
Lobular cancer.
you can say first, large tumor in relation to breast size. So for example, if a woman have very large breasts and the tumor is 4 cm, you can still do breast conservation therapy. But if she has small breasts and tumor is 4 cm, you can't do that. Okay, so large tumor in relation to the size of the breast. That's one thing. That's one. Tumor to breasts size ratio, you can say. That's most important thing. That's an indication for mastectomy. The other indication is, as you said, multicentric disease, multicentricity or multifocality. Okay. The other thing is DCIS. Why? If it's diffuse DCIS. Why? Because there will be recurrence. If there's diffuse DCIS in the breast with one focus of cancer, if you remove only focus of cancer, the other will become cancer. So if there is diffuse DCIS, you cannot do mastectomy. And you need to do mastectomy. Sorry. The other thing is if it's BRCA positive. If the patient have BRCA mutation, you need mastectomy because very high risk of tumor coming back again. There's genetic passes. Actually, BRCA, you need bilateral prophylactic mastectomy. The other breast needs to be removed as well. The other indication for PATI, recurrence after breast conservation therapy. There was a question about that. I will come to it, okay? Finally, patient preference. So those are indications for mastectomy in early breast cancer. Number 1, large tumor in relation to breast. Number 2, multicentricity or focality. Number 3, diffuse DCIS. Number 4, BRCA positive. Number 5, recurrence after BCS, breast conservation surgery. And finally, patient onset. Now, let's focus our attention. Is it clear up to this point, guys? Clear?
Yes.
Okay, good. So let's see BCIS now, breast conservation surgery. Breast conservation surgery, what's the meaning? The meaning is that that's the tumor. We want to achieve 1 cm RO resection. RO means, there are terms that you need to know, guys. RO, R1, R2. RO means no microscopic or macroscopic deposit at the margin. R1 means microscopic, only evidence of disease at the margin. R2 means both gross and microscopic evidence. Our aim in breast conservation therapy is to have 1 cm RO. That's the aim. Okay? Okay. Now, the question that comes in the exam, if suppose you did breast conservation surgery, okay, and pathologists say after surgery, pathologists say margin involved. What is your next step? Your next step is what? Are you gonna convert to mastectomy, or you will do re-excision, or you will give chemotherapy only, or you will give chemotherapy first, then mastectomy? So what's your answer, guys? Again, question is, that comes in exam, female comes, we did breast conservation surgery, we removed the tumor. After the surgery, pathology say margin involved, means incomplete resection. What you want to do? A, Option A, re-excision. Come again and remove again. Option B, go for mastectomy. Option C, go for chemotherapy alone. Chemo alone. Option D, chemo, then mastectomy. So what you do? What we do is re-excision, called cavity shave. Cavity shave. Cavity shave means what? Means that you come back again and excise the cavity of your previous excision. That is allowed once, meaning that breast conservation therapy, margin involved, cavity shave. If after cavity shave still involved, mastectomy. If not involved, then okay, thank you so much. Okay? So cavity shave is allowed how many times, guys? Once. Okay. So it will be not fun to say what are the indications of breast conservation surgery. The indications will be the opposite of the ones that we discussed in mastectomy. The opposite, right? Patient wants it. It's not BRCA. There's no DCIS. And small in relation to size of tumor. In all textbook, if you open, they tell you if tumor is central, you go mastectomy, but that's, you can do it now. You can do it central even, okay? Central tumor. In addition, you have to avoid breast conservation surgery if patient have contraindication for radiotherapy, because that's needed. Radiotherapy after or is needed. So contraindication like what? Most patients with collagen vascular disease, like SLE, right? Like also patients with ankylosing spondylitis have severe radiation reactions. Patient with severe orthopnea, they cannot, lay down for a long time for radiotherapy to take effect. So this is in terms of surgical therapy for tumor, local. Now, what about axilla? What about axilla? Axilla, you have two options. Treatment of axillary disease. You have two options. Option one, surgery. Option two, radiotherapy, but never both. Never both, okay? Because both, you destroy most axillary lymphatics, and patient develop lymphedema of the limb, and later on may develop lymphangiosarcoma on top of it, called Stewart-Trevis syndrome. So it's a huge headache, big deal. So remember, never both, okay? That comes in exam. Either this or this, but not both. Okay. So what we do in surgery for axilla, first we do sentinel lymph node biopsy, which is what? You inject a material like methylene blue, a dye, or radioactive albumin in the tumor, right? So that you can detect the first group of nodes which drain the tumor-bearing area. That's sentinel lymph node biopsy, and target that. This is level 1 dissection, okay? Level 1 dissection. Okay, so further treatment of the axilla will be indicated if sentinel lymph node biopsy was positive, okay? You need 3 or more nodes. 3 or more nodes. Meaning that one sentinel lymph node positive is not enough to treat the axilla. You need 3 sentinel nodes or more than that to treat the axilla. That's one indication. Okay. Or if it's already obvious axillary disease, there is biopsy proven disease, you don't need sentinel lymph node in that case. You go ahead and treat the axilla. Okay? What we do is level 1 and 2 dissection. Level 3 is not indicated unless 2 is involved. It's not standard part of the operation. Okay? I'll be impressed by someone. if they tell me what are the contraindications for sentinel lymph node biopsy?
Methemoglobinemia.
What? Anyone knows a contraindication to sentinel lymph node biopsy? That's if you say enlarged lymph node that already diseased there, it will not be indicated in the first place. I mean, a contraindication, not something which is not indicated. A contraind, you can't do it. No, not perineal invasion. Let me tell you.
Allergy, pregnancy to the dye.
You can always use another type. You can always use another type of dye.
Inflammatory breast cancer, I think.
Very nice. Yeah, that's one. Yeah, inflammatory breast carcinoma. 2.
Pregnancy?
Not necessarily, but it's not absolute. But if patient have prior history of schist wall trauma or schist wall surgery or burns to the breast or prior radiotherapy to the breast, this means that there are a lot of scarring in the breast. So if there's trauma, burn, surgery, radiotherapy to breast, means there's a lot of scars in the breast. So it means what? It will not be reliable if you do sentinel lymph node, because that will distort the lymphatics. It will not be reliable. So 2 main contraindications: inflammatory breast cancer and prior scarring in breast, whatever the reason is. Okay. So we discussed about surgery, we discussed about axilla, and we discussed about neoadjuvants. Final thing that I want to add is adjuvant therapy. Adjuvant therapy. This is the answer to this question, okay? So let's talk about here adjuvant therapy. Adjuvant therapy. Adjuvant therapy can be adjuvant radiotherapy, right? Can be adjuvant chemo, can be adjuvant hormonal therapy, and finally targeted therapy, okay? So adjuvant radiotherapy, when should you need that? Anyone can tell me indications for that? I told you one already. I told you one already, which is after breast conservation surgery. You always need it. Okay. That's one. Second, you will always need it if there is locally advanced breast cancer, which is defined as T3 or T4. You will need it if tumor size, after mastectomy, if tumor size is 5 cm or more, with a skin or schist wall involvement, or with lymphovascular invasion or grade 3 histology. So, grade 3 for lymphovascular invasion. Okay. That's main indication for radiotherapy. Now, indications for chemotherapy. Indications for chemotherapy. Look, according to Bailey and Love, indication number 1, tumor size is more than 1 cm. More than 1 cm. Or tumor size more than 0.5 cm, but with poor prognostic factor. Poor prognostic factor, which means what? It means LVI, lymphovascular invasion, or it was HER2 positive, or it was triple negative. Finally, positive lymph node. So in this patient, in our patients, do they have indication for chemo, systemic chemo?
Yes.
They have multiple indications for systemic chemo, right? First, size of the
Tumor
tumor.
size.
That's clearance, clearance margin. Second, they have HER2 positive tumor, and they have positive nodes. So there are a lot of indications in this case to start chemotherapy. So we know chemotherapy will be indicated in this case, but also targeted will be indicated because it's HER2. So we'll give option C, okay? There is cytotoxic chemotherapy plus Herceptin will be given in this case, both. Okay, indications for hormonal therapy if they have estrogen receptor positive disease. So it's so important in the exam, hormonal therapy, to know what to give in pre, what to give in post menopausal women. For pre-menopausal women, we give what? Pre-menopausal, we give what? Yes.
Anastrozole.
So
pre
tamoxifen.
Tamoxifen. Okay, so pre, we give tamoxifen. And post, we will give like anastrozole or letrozole, right? That is aromatase inhibitors. Aromatase inhibitor. Okay. Okay. I would love to talk about staging and Nottingham, but I think that would take a long time. So I hope that was beneficial. I only talked like very summarized. Okay, let's see the next question. We made a lot of mess here. Let's remove all of that first. Okay. Yeah, okay. Question 53, can you see it? Yes, doctor.
Question 53. Which of the following is a muscle of respiration? Expiration.
Expiration, yeah.
Well, in passive expiration, there is no muscle involved.
What?
And diaphragm.
Muscle of expiration. Exhalation, expiration. Yeah.
Internal intercostal.
Internal intercostal. Also, rectus abdominis have a rule, by the way, but internal intercostal, that's its sole function, that it's a muscle of active expiration. Okay. I remember one of our students who had the previous exam, he said he didn't know it, but when he looked at it, he said muscle of expiration. It must be external oblique, external intercostal. So I told him that can be a good mnemonic, but you keep in your mind to reverse it, right? So you say expiration, external intercostal, but I know it's inverted. So expiration, internal intercostal. That must be the weirdest mnemonic in the world. Okay, let's see the next one.
Question 54. A patient is diagnosed with high membranous ventricular septal defect. This defect is most likely due to abnormal development of which of the following?
Diagnosed with high. Okay, so in the website there's a lecture about embryology of the heart. Okay, the answer to this, for purpose of exam, if you don't want to know the underlying for purpose of exam only, just memorizing it, it's bulbous cordis. But I advise you to see the lecture, because a lot of important points can be there. Bulbous cordis. Okay. Which bulbous cordis give rise to what? Give rise to the outflow tracts of right and left ventricles. Okay. So a high membranous defect, which is outflow portion, VSD, that is caused by problems of development in the bulbous cordis. But anyway, let's see the next one.
Question 55. Which of the following is first phase in bone healing? Hematoma formation.
Yeah, hematoma formation, then inflammation, right? After that, soft callus, then hard callus, then finally rheumatism. Okay.
Question 56. The duodenojejunal fracture is normally present at which of the following locations? It's D. To the left of the midline at transpyloric plane. C.
Yeah, B. To the left of midline, transpyloric plane, roughly at that plane. Okay.
Question 57. A 28-year-old patient presents with chronic diarrhea and abdominal pain. Colonoscopy reveals a cobblestone appearance of mucosa, which is histological finding is most characteristic. A.
Yeah, that Crohn's disease, isn't it? Cobblestone appearance. Going with Crohn's disease. Crohn's disease, most important is to pathological finding. It's not always present, but the most important is non-caseating granulomas, right? Non-caseating. Okay.
Question 58. A patient presents with severe chest pain and abdominal pain radiating to the back, upper limb weakness, and pale lower limbs. Afterwards, she collapses. Which investigation is most appropriate to diagnose the underlying condition? Okay. CT autogram.
Yeah, so I watching this section, right? Investigation of choice is CT aortogram. It will show the dissection, it will show the level, it will help in surgical planning. Okay.
Question 59. A 45-year-old female presents with jaundice and is diagnosed with CBD stones. Which of the following would not typically be elevated? Acid phosphatase?
Yeah. It should be alkaline phosphatase, right? So
Yes.
acid phosphatase will not be elevated. The others will be elevated. Phosphatase will be elevated. GGT elevated. AST also elevated. Bilirubin elevated. All of them will be elevated, except the acid phosphatase not. Okay, let's see the next one.
Hyoscine is used to relax smooth muscle in GI tract. Which of the following receptors does it primarily act on? Three.
Yeah, so hyoscine or scopolamine, also called scopolamine or hyoscine, it's used as a smooth muscle relaxant, right? Smooth muscle relaxant. How does it do so? It acts on M3 receptors, muscarinic receptors, M3 receptors. Okay, let's see the next one.
Question 61. A 50-year-old man has recently underwent orchidectomy for testicular seminoma. On further investigation, he is found to have lumbar lymph node metastasis and is scheduled for retroperitoneal lymph node dissection. Following the operation, he complains of inability to ejaculate during sexual intercourse. Which of the following has been, okay, it's a sacral? No, lumbosacral trunk.
Mhm. Lumbosacral trunk is part of sciatic nerve, right? The part of L4 and whole of L5 comes down to the pelvis as lumbosacral trunk and then joins the other sacral roots to form sciatic nerve. It's not related to ejaculation, lumbosacral trunk. Not related to it. Sacral splanchnic nerves
Sacral splanchnic nerves.
are those sympathetic or parasympathetic or what? Sacral splanchnic. Yep, those sympathetic. You can say sacral sympathetic. Sacral sympathetic. Pelvic splanchnic, pelvic parasympathetic. Right? But those are not for pelvis sacral splanchnic nerve. Don't be fooled by the name. It's actually for peripheral distribution to the lower limbs, like blood vessels, skin, etc., of the lower limbs. So sacral splanchnic nerves doesn't supply things in pelvis. Those are for peripheral distribution. So it's not the answer. What about hypogastric nerve? Do you like that answer? Does it seem? Yeah, that's correct answer. What a hypogastric nerve. Look, the story begins at L1, L2 level, where preganglionic sympathetic fiber leave as lumbar splanchnic nerve. That relays in the pre-aortic plexus, which is superior hypogastric plexus. This is aorta, and of course it bifurcates at L4 or supracrystal plane. There's a plexus anterolateral to the aorta, called superior hypogastric plexus. Just a plexus of parasympathetic and sympathetic nerves intermingled together. Inferiorly, they divide into two nerve bundles. These two nerve bundles are called hypogastric nerves. These are called hypogastric nerves. They have very important story. What do? They enter the pelvis and join the inferior hypogastric plexus. Okay? Okay. They contain two types of fibers. Descending fibers, which are sympathetic for the pelvic organs, like bladder, penis, those rectum, for the pelvic organs. Okay? Sympathetic fibers. Those are descending down. And there are those which are ascending, moving up through the nerve, to go to the abdomen, to go to the hindgut. Those are what? What kind of fibers ascend through the hypogastric nerves?
Visceral.
Yes?
Visceral afferents.
No? Yes, but I mean, what supplies hindgut? Ascending up and supplying hindgut. Parasympathetic fibers. Look, guys. No, not least. I'll come to least splanchnic later. It's not least splanchnic. Look, the foregut and midgut parasympathetic supply is by vagus. Okay, simple. Vagus nerve supply that. But hindgut is supplied by pelvic splanchnic nerves. Some of the pelvic splanchnic nerves ascend, the parasympathetic fibers contained within, ascend up through the hypogastric nerve to enter the superior hypogastric plexus, and from there, through the blood vessels, goes to the hindgut, supplying the hindgut. Okay. All right. So hypogastric nerve contain two types of fibers: descending sympathetic, which supply pelvic organs, including penis, for erection, for ejaculation, and the prostatic glands, the seminal vesicles, all of that, for the action of ejaculation. And ascending parasympathetic fibers for hindguts. Okay, so answer should be Option B, hypogastric nerves. Is that right? Okay. Okay, let's see the next one.
Question 62. A 12-year-old girl has family history of medullary thyroid cancer, is undergoing genetic screening, which is the genetic mutation associated with familial medullary thyroid cancer. It's C, Retroperitoneal.
Excellent, right? RET, proto-oncogene mutation, is the one linked to medullary thyroid cancer. Papillary is linked to two main genes, PTC1 and PTC3. Just in case they ask you. PTC1 and PTC3. PTC1 is associated with milder, late occurring form of the disease, but PTC3 is poor prognosis. It's associated with earlier, it occurs at early age and more aggressive disease. Okay, just keep those notes just in case. Okay, let's see this one.
Question 63. A 20-year-old man is involved in RTA. In the emergency department, he is found to have deformed hand and complains of pelvic and back pain. He is initially conscious. Which of the following is best next step? Arm reduction. Okay. We'll start with A, B, C, D.
Yep.
So it's blood pressure, capillary refill, JVP, skin temperature if he's cold and clammy, and yeah, he is also going to be not very conscious, not alert.
Yeah, so it means we just check blood pressure and heart rate initially to begin with, right? It's a part of the ABCDE. When we reach the C, we measure blood pressure and heart rate. That's one of the measurements that we do. That's the best next step in this case. Okay. Okay. Let's see the next one.
Question 64. A 78-year-old patient with diabetes, atrial fibrillation, hypertension presents with sudden sharp pain in right lower limb, which is pale and cold. What is the most likely finding on CT angio? Okay, it's A.
Excellent.
I think
yeah.
it's A.
Acute limb ischemia, right? The characteristic angiographic finding is a tapered and abrupt cutoff, right? In angio. Okay, so it's a simple question. This one, okay, let's read it, but there's another form of it that was reported. So it's essentially the same question, but let's see that. Let's see it.
Question 65. A patient presents with injury to tibial component of sciatic nerve. Which of the following muscles would be spared? Short head of biceps?
Yeah, because that's supplied by the common peroneal component, right? The rest of the muscles mentioned supplied by tibial component. Okay, let's see this one.
Question 66. Which of the following structures will need to be divided during open appendectomy? Will need to be divided. Okay. Divided means cut. It's aponeurosis. Yeah, external oblique aponeurosis.
Yep.
No. Is it aponeurosis or muscle?
No, aponeurosis.
That will divide it. Oh, okay.
Yes, Dr. Muhammad, the question is 64. Here it is. Okay. That's the question that you asked for, doctor? So just simply telling you, this patient has atrial fibrillation, okay? Diabetic and has atrial fibrillation. And then he presents with sudden sharp pain in his right lower limb. So this is embolic occlusion, right? Embolic occlusion. Most likely acute limb ischemia because you have embolic source. Is that right? So they want on angiography, CT angiography, what you see. What should you see? Okay. If we consider the options, let's see one by one. Arterial pseudoaneurysm. There's nothing in the case that lets us think about that, right? Usually arterial pseudoaneurysm are in the context of either accidental or iatrogenic trauma. None of that is mentioned in the case. Okay. Option D, focal occlusion of superficial femoral artery with good collaterals. That doesn't align with the case because good collateral means there have been chronic ischemia. For the collaterals to develop, okay? Chronic limb ischemia. They didn't mention that in the case. They didn't say that he was complaining of claudication or wrist pain, and then he developed acute. It was just sudden presentation. So that doesn't align with it. It does not align with it. Multiple filling defect also does not align with acute embolic occlusion because embolic occlusion simply that's a vessel, that's an embolus inside. Nothing else, okay? Diffuse narrowing of superficial femoral artery means there's atherosclerosis. Diffuse narrowing means atherosclerosis. Again, that doesn't align with chronic limb ischemia. So we're left with option A, right? And it is a well-established known finding that you will find there's a cutoff, tapered cutoff. The vessel was okay, but when you come to the site of embolus, there's a cutoff. So that's the finding. It aligns with the history in the case. Okay, makes sense? Okay. Yeah, that's 67. Yes, let's see 67.
A 60-year-old female presents with pain and tingling sensation over the thumb, especially at night. She also complains of objects easily falling from her hand. Which of the following is best investigation to confirm a diagnosis? Nerve conduction studies.
Yeah, okay, easy. Let's see the next one. Yes. Yes, doctor, are you with me?
Hello?
Hello, I can hear you. Can you hear me?
Yes. Is it nerve conduction studies? Option D?
Yeah. Yes, yes. I mean, what about the next question? Can you see it?
Yes. Question 68. A patient undergoing general anesthesia develops sudden hyperthermia, muscle rigidity, tachycardia, hypercapnia. Which of the following drugs is most likely responsible? A.
Yeah, so it's malignant hyperthermia, right? Okay. Okay, guys. So we reached the end of this session. Next, we will have mock exam. This mock exam is composed of 100 questions. It will be just like exam environment, that there will be a minute for every question. You will be able to move between the questions back and forth.